Hello, everyone, and welcome to today's AHA team training webinar on challenges for hospitals creating and maintaining high reliability, which is brought to us by our very good friends over at Relias. My name is Mitul Patel. I'm a senior director with the American Hospital Association, and I have the pleasure of serving as your moderator for today. Before we jump into the good stuff, a couple items of note. First, you're in listen-only mode, but if you do have a question for the Relias team as they go through their discussion, please type it into the chat function. We will save a few minutes at the end of this discussion for Q&A, and I'll read through the questions and we'll try and get through as many as we can. If we don't get to your question, we'll be sure to follow up with you offline. Secondly, no worries if you miss a point or a note or a factoid on a slide. We are recording this session. So along with the recording, we'll also share with you the slides after we wrap up here. So with that, I'd like to introduce today's presenters from the Relias team. We have John Harrington, who's the Vice President, CMI. And then also Laura Sparkman, who's the Vice President of Patient Safety and Quality. So John and Laura, I'll turn it over to you. Thank you so much.
Thank you very much. It's an honor and a privilege to be here today. And we're going to do a brief introduction of each other. And I'm going to pass over to my colleague in a moment, Laura. My background is in medicine and art, and I'm board certified in biomedical education. So those of you who are familiar with Frank Netter, Medical Illustrator, that's the space I come from. I started a company that serves hospitals all across the country in two forms: in helping support through demonstrative evidence in the courtroom, in the medical malpractice arena, to help jurors understand the complicated nature of what happens in trials. And then more importantly, teasing out from those experiences salient risk management messages and turning that into proactive education and training. So honored to really share some more of our story today and our 20+ year journey in quality and patient safety. So I'm going to pass it over to Laura Sparkman right now.
Thank you. Good afternoon, everybody. I'm looking at all the chat. Everybody's checking in and saying hi from all over the country. I love that. I'm in downtown Kansas City. This is a real background. I know everybody's used to having a fun background, but I'm in downtown Kansas City. So hello to everybody and across the country. I am the Vice President for Patient Safety and Quality. I've been with the organization for over 5 years, but prior to that, I was with the organization that created really a paradigm shift in adult learning and education. My expertise is in patient safety and improvement. And then prior to that, I was with Ascension Health for over 17 years at the system office, where I led big multi-hospital improvement projects around high reliability, and really how do you influence behavior change to create to get to better outcomes and less risk. So really happy to be here with you today and be talking about high reliability.
Thank you, Laura. So for those of you who do not know Relias, we joined the Relias family about 5 years ago through an acquisition. As I mentioned, I started a company, really was incubated in the Harvard system for the first 10, 15 years of the business. We grew pretty rapidly to a point where it made most sense for us to join forces with Relias. Relias is an organization that's focused in post-acute care, HHS, and acute. And so today we're going to talk about high reliability as it relates to OB, but of course it's more ubiquitous than that. We are going to talk about how it goes all across the entire continuum. A little bit about Relias. Our mission is to measurably improve the lives of the most vulnerable members of society and those who care for them. And so that's really, you're going to hear a lot of that today, the passion for the mission that we all share. It's inside of Relias. All right, so let's talk about just a little housekeeping, learning objectives. The first thing that we put together today as a presentation, really want to go back to the evolution of the patient safety movement and lessons learned. It's been 20 years since the IOM report came out. So there's a lot of lessons that we can learn from that we can glean from that experience. This presentation will always also allow you to gain insight into key drivers associated with variation in care, amongst clinical teams. Variation equals risk. How do we identify variation and how do we remediate that? We're going to refresh initiatives in building a culture of high reliability within your organization to improve patient care. You know, that old adage that culture eats strategy for lunch. We're going to talk a lot about the importance of culture in creating a highly reliable team. We're going to learn how to successfully implement change initiatives for mitigating clinical risk, and understand the challenging landscape of where we are today. 20 years now, forward, what are the challenges that we're facing in healthcare? So when Laura and I were putting this presentation together and with our team, we started thinking back that, in 20 years, there's a lot of people I suspect on this call that are somewhere in their career, right? Somewhere in that arc. So some may be new to healthcare, some may be in their early nascent stages, 5-10 years, and others like Laura and I in the 20s and 30s. And we thought it'd be a great opportunity for us to just go back and really talk about what we learned. Many of us on this call, I'm sure, lived through that Institute of Medicine report that changed the entire paradigm. So we thought, let's start there and then go again, tease out the salient messages and the lessons learned and how we can apply that to the challenges going forward. So I'm going to turn this over to Laura to kind of lead us out on the IOM report and what that meant back then and what it meant for her in her capacity at Ascension Health.
Thank you, John. So, again, I think this is the landmark moment in healthcare history that really changed our view about our responsibility in acute care. And then, of course, beyond there, the continuum. But back in the day, and again, John already mentioned, we're, 20, 30 years deep in our career. So hopefully we've, we like to say to each other, we're aging well. But the Institute for Medicine, this report, I remember being at the system office at Ascension Health. We were hosting a system-wide meeting. So this is all the senior leaderships from across, over 100 hospitals, and our senior leaders who I had the great fortune of having direct access and reporting to, the chief nursing officer, the chief medical officer, et cetera, and the risk officer for this organization, and really having insight into that level of thought leadership. But we really digested this report because it really started to tell us that we need to do more, we need to do better. What are ideas of safe care and what quality was not good enough. And people that went to the hospital, the attitudes of the care team, I'm a nurse by background, critical care. I've had a smattering of experience like many nurses do across the acute spectrum, and, some administration as well. But, you start to say, oh, somebody, died or there was a mistake. And back in the late 1990s and early 2000s, we really did not have our hands around the scope of the problem and even standardized, reporting. So this was kind of a shock to us. And for the first time, we really put forth a call to action. I think a lot of hospital systems think about it that way, but we put a call to action for zero preventable harm. We actually worked directly with Don Berwick and teams at the Institute for Healthcare Improvement. We were one of the very first large multi-hospital systems to work directly with the leaders at IHI in creating, I know Ascension's journey was the journey to zero. And that was, kind of the background and where I went deep into patient safety, science, education, training, and really how do you influence change? You can't make change, but you have to influence people to want to change and to get on board with this. So that's why culture, you'll hear us talk about this, plays a big role. But from my leaders, I want to say that we created something that was pretty groundbreaking at the time, which was a metric, a measurement around unintended, unexpected mortality. Clearly, people we know go to the hospital and we know they're having their last days there. That's intended. But for unintended, mortality. That's really where we wanted, and harm, right? It broadened out from mortality to morbidity and harm. And that's really where we, started our journey. And we built, goals, and the journey for us started back in 2003, 2004, 2005, where we really created the organizational structure to support this journey to high reliability that we wanted to embark on.
That's good. And as you can see from the bullet here, that at that time, we estimated between 44 and 98,000 deaths every year occurred in hospitals are preventable. And we're going to speak later. We know that was woefully underestimated. Some of the other work that we did early on in identifying areas of focus was working with quality and risk management to look at these injuries, look at where we saw the severity of injury as it relates to different areas. As you can see here, that's why OBGYN for us became a big focus. Is, sadly, the untoward outcomes, the adverse events in that space are so catastrophic to the family, to the hospital system, to the third victim they often talk about is the caregiver. So that was an area that we really felt that there's a lot of focus. And you're going to see in a moment the reason why. System errors really attribute mostly in that area. So with medicine and surgery interventions are really challenging. How do you change that model? But when we know so many of these adverse events can be attributed to a breakdown in the care team, it gave us an opportunity to really look and create highly reliable teams.
John, if I could add real quick to that, the other piece of that is that while medicine, surgery, you're looking at, like, again, the total number of events was high, but the claims around that were generally for an event a much lower amount, versus something like OB or maternal or neonatal harm, lower numbers, but a much higher risk claim opportunity per event. So that, again, you have to look at all of those facets of these areas.
Absolutely. And the other piece too is what we learned in that early work, and what still stands true today, is what you see in the papers, what gets publicized: wrong site surgery, retained foreign bodies, the $20 million to $30 million cases. That's not the issue. What we know from research, what we know from data, is that it's the routine procedure performed by an experienced surgeon in the sort of the analogy they often use, the last ski run of the day, where you're in a place where maybe your defense is down, maybe you are less focused on the events or concerns. And this early studies or early research that really led the charge of what we needed to do and to address that is to really build systems-based approaches to reduce the risk. It's no longer about how vigilant a physician or a nurse can be. It's about creating a safer system around it, because to err is human. We know we're going to make mistakes. We know we're fallible. So creating a system to address that really, once you understand, like Laura said, this shined a light on a room that was dark for centuries. Now we knew what we need to focus on, and these are the areas that organizations really are doubling down on. So I'm going to turn this over to Laura. This is some of the other work that we learned where systems factors really increase the likelihood of errors. Go ahead.
Exactly. Yeah. So we wanted to just kind of talk about incidents by contributing factors. So again, this is, definitely dated. We actually have more current data on this, but I think it's good to know as we're talking about this journey about kind of where we were and where we are today. But back then, I mean, the fact of the matter is these have maybe improved some, but they still represent the common reasons why adverse events happen and in the volume. But if you look at system factors, inexperience, lack of confidence, communication breakdown, competence, communication breakdown, excessive work, fatigue. We know, I mean, think about COVID right now. How much has that played into this over the last 2 years? We don't even know yet what's coming. Things have been on hold. Interruptions, distractions. There's been a lot of work around creating quiet zones for medication safety and that sort of thing. Technology, equipment, failure, administration, complexity, bureaucracy, inappropriate protocol. And so we actually even have more data that that's coming out of some other reports. And I think we're data rich, but we have to make sure that we're really, you as an individual leader in your own organization, understand from those root cause analyses and the data that you're collecting, what are the factors that are contributing to your near misses, your serious safety events, and the harm that's happening at your organization.
That's great.
So additionally, John and I, we found this article a while back, but it meant like it just totally resonated with us, because Atul Gawande literally was saying, like, I need a coach, right? This is what this article was all about. And it talks about why in the medical industry do we think that we're unique and special and better than other industries. So like healthcare is a high hazard industry, and think of education, training, data as supportive tools that coach you as a clinician to get better. We love to flatten the hierarchy. We know the roles of all the team members on the care team, but long gone are the days of when we have a big personality and a title that is directing, but you really need to have that personal coach. So we love this quote: no matter how well trained people are, few can sustain their best performance on their own. That's where coaching comes in. And so that's what education, training, models around high reliability come in. John, anything you want to add around that?
No, I think you're absolutely, other than someone on the call, I would love to hear your comments in the chat. Some were probably thinking it seems so obvious, but this was so frame breaking. It was almost silly to look back and to think that this was novel. But now, fast forward, we're going to talk about where we are today. But we completely flipped that challenge. Like, I love the way you said that, Laura. We flattened that hierarchy, which was really causing a lot of this harm. It was the idea that this one individual was in charge of everything, and hopefully they white knuckled their way through that challenge, or that's how it ruled the day. Creating systems-based approach means that everybody's part of that. We're all sharing that. I don't think anybody on this call would like to think that we're completely dependent upon that pilot. Right? That doesn't happen in the airline industry. We have systems, we have programs, we have checklists. We've created all kinds of safety issues to make sure that we're not completely dependent upon the individual who is fallible by virtue of being a human. So that's what systems-based approaches to reduce risk and improve outcomes are all about.
Exactly. And so to John's point, if you guys can think about this, we'd love to hear your comments in the chat on this, because in hindsight, it would have been fun to have a little poll there that says, do you think doctors need coaches? Do you think nurses need coaches? Do you think C-suite administrative leaders need coaches? And then what would that look like, even from your own personal experience? So we appreciate your comments there.
So I'm going to go quickly through some of the applications of that. So we mentioned what we identified, and we also recognized what we could do about it. And then this whole work you're going to hear right now was the genesis of Team Steps. The Team Steps, I'm certain all of you on this call are familiar with that program, but this just demonstrated how effortless it was, as it were, or effortless it still is, to improve culture when you focus on it, when you bring everybody together. And so this was pre-training, post-training, dramatic improvement. This was published in an OBGYN article way back when that just showed that this approach, this changing the culture, creating a shared mental model, creating a common language, had a direct correlation in improving outcomes and reducing risk. I'd like to say that that's ubiquitous in healthcare and perinatal, but it still isn't. It's still not. It's something that we're constantly working on every day. But that leads us to lessons learned and where we are today. So as we said in the outset, we wanted to kind of go back through the patient safety movement, fast forward to where we are today, and then some of the what we can apply from what we learned over time and what's working for systems just like yours, and what you can take away from this conversation today that you can apply back in your own experience. So Laura, can you walk us through this slide of where we are today in the patient safety movement?
Exactly. 2 decades after the IOM report, and like 20 years, right? We know that the predicted number of unintended death is so much higher. And we know we have so much more insight. We're so much more prepared, and we have many success stories and tools to help us do that. So we know the number is still high. And so, 8,220 people die in hospitals every day in ways that could have been prevented. We know this. The US is third in the leading cause of death. Medical errors is the third in the US. The large number, very, very underreported. And 3 million people are estimated to die globally. So this is not just a problem in the United States, it's a global problem. And I think when John and I were preparing for this talk, we were thinking like, yeah, we have been doing this for, 20, I've been a nurse for 37 years. Back when I was a new nurse, none of this was even on the radar screen. It started to, show up much later down the road in my career. My daughter is a nurse now, and I think about all the education and training that she's required to do now. And so in some cases, we probably over-engineered the system. In other cases, we still need to do more work. We have things like a maternal mortality crisis where women die in the US higher than any other first world developed country. So this is the kind of data that we can actually truly make a difference on. But if you think back, this was a shock when this report came out in the Lancet in 2015. And now the Joint Commission is involved in the CDC, and we have these maternal mortality review committees, and we're getting the detail on the data. And what's interesting, when they went back and these maternal mortality review committees did that root cause analysis and started to understand how women are dying in this country, it's still around wrong diagnosis, delay in treatment, lack of assessment, lack of communication among the care team, lack of teamwork and communication, not using standardized protocols, all the things we know, but we know we still have independent thinking, we don't have systems thinking, we don't have team-based care, and we're still managing that. So I think, to kind of spill the beans, there isn't any bright, shiny new tool in this work. I think what we're going back to, and I see that comment for non-Hispanic Black women, they do die 3 times higher than non-Hispanic white women. Social determinants of health, implicit bias, racism, all of these factors are contributing to that. And really for the first time, we're getting a really deep insight into that. And we have an unprecedented opportunity to make a big change on that. So John, anything you want to add around that?
I think that's fantastic. I think that we're sort of at this place where that all seemed pretty bleak, but it's important, right? We can't manage what we don't measure. So that's part of what we really need to focus on. So understanding the problem gives us an opportunity to launch remediation. It gives us a call to action. And so that's what the next part of this conversation is going to be about, is the good news. We're going to share some studies, organizations who are applying best practices and having a direct impact on reducing adverse events and untoward outcomes. So the first thing we're going to talk about is identifying and reducing variation in care. So you heard us talk about that at the beginning. That's really what is occurring here. That's variation in care leads to normalization and deviance, right? It leads to individual siloed approaches. We know from everything that we've learned along the way that that is the greatest challenge. 78% of adverse events in perinatal in particular can be attributed to breakdown in the care team. So we need to reduce that kind of variation. So the first thing we need to do is let's look at the tenets of highly reliable organizations. So when we talk about, and again, I want everybody in this call to think broadly, because even though we're using an OB example, because with the limited time we have, we want to kind of really go right straight to directly show you that direct correlation. But obviously, everything we're talking about is universal across the entire continuum in healthcare. Everything about high reliability applies to the work that you're doing in your organization, no matter where you are on that continuum. So I'm going to turn this over to Laura to speak about the 5 principles of a highly reliable organization.
Thank you, John. And I, we want to pause here and just make sure that we spend a little, a minute or two on this, because we did receive some questions ahead of time that, people are asking, like, how can we keep moving forward with high reliability? How do you make it part of the role of the frontline caregiver? And I could say, these 5 principles have been in place again, for, also a couple of decades. And they're still true today. And I just want to spend a little time on each one. So preoccupation with failure. High reliability organizations cannot ignore failures because they can snowball into a tragedy. So this means that employees at every level in a highly reliable organization are tasked with thinking of ways their work and processes might break down. So it's important to address that at a technical, human, and a process failure. So if you're engaging your new hires and your current team in that kind of thinking and expectation, like they are part of the solution, and you'll hear us talk about this culture, that's how you start to embed this. The reluctance to simplify. HROs are complex by nature. We are in the company of nuclear power plants and, airplane safety. Hospitals is a high hazard industry, and leaders need to be open to changing long-held beliefs and continue to look at data, benchmarks, and performance metrics to prevent simplification. Sensitivity to operations. Understand that getting a good understanding of the current situation involves working with frontline employees because they are closer to the work. So we have to listen as leaders. I call it servant leadership. You lead, we'll follow. I learned that a long time ago from my CEO at Ascension Health, Dr. Tony Tersini. That was a battle cry at Ascension Health, who's been a thought leader in high reliability, and I still carry that with me in my toolkit. I've been doing that for 30 years and moving that work forward, and it still resonates with me today. And then because high reliability starts at the top. So if you're demonstrating that at the leadership, you can't, John and I were talking about this, you can't identify to say, oh, you're the vice president of patient safety and high reliability. You're responsible for that. I'm not responsible for that. That's not the case. Everybody has to own it. And that is the job of leadership, to walk the walk, talk the talk, and put it in place and keep pushing. This has to be how we work going forward. Commitment to resilience is part of that. Resiliency. This is something we have seen. Organizations that have high reliability in place and continuously work on it and focus on it in COVID, they had better outcomes than some of the organizations we're working with and consulting with that have bits and parts and pieces and strong performance here and there throughout the organization, but it's not pervasive. So it helps you, high reliability concepts help you maintain the resilience no matter what we are confronted with, and a pandemic was a doozy. And then the deference to expertise. Again, organizations, leaders must know who in the organization possesses these specialized pieces of knowledge and the skill set. They must also encourage people to become experts and also help employees reach their mastery so they can help carry this high reliability forward. And their absence or when they're on, and they're the leader. And you value that. And it's not about titles or authority. It's about culture, and everybody is engaged in doing what's right for your organization and for your patients and for your care team. So John, anything you add there? I wanted to, do a little deeper dive on that, because this is what I was saying before, where if you do this, you will see improvement. And if you incorporate it and it's part of your culture and it's how you do work, you will see improvement in your outcomes.
Yeah, the one comment I would make was the commitment to resilience. And we did have one we shared anecdotally together when we were preparing this. One of the hospitals that we were speaking to had could be categorized as a near miss, where a patient was transferred out of the emergency department by an ambulance that went to the room instead of the patient. So the wrong patient was removed from the hospital, created a risk for the organization. And this individual shared with us that I didn't think I'd be talking about those types of issues. Those are things we thought we had knocked in pre-COVID, and now we're just backsliding that behavioral drift that happens. That's again human nature. And so that commitment to resilience, to keep doubling down on this work is crucial, being ever vigilant. So we're going to talk about, as we keep mentioning these best practices, so you're thinking these are things that you can apply. We're going to give you some case studies, examples of organizations who are doing this and tremendous impact they've had, so that this is the, as I said, the encouraging part of the conversation. So there's three components that we see out there that lead to creating a highly reliable team. First and foremost is identifying that variation. Identifying that variation, not as in a punitive way, but as an opportunity to help that individual improve. How do we create shared mental model? How do we create synergy between the whole team? Let's identify knowledge gaps and let's remediate those knowledge gaps. So that's basically where we start. And that has to come from an assessment in some form, just to understand, have a measurement so we know how to manage. The middle slide is where we speak to what we're seeing is the most effective out there is personalized learning. Right? There's nothing more frustrating than trafficking through education that you're already competent in. So we have to flip that. We have to find a way to test you out of information that you already are competent in and inspire your learning by telling these are the areas you need to traffic. And once we do so, that creates an entirely different learning environment. It's antithetical to click, 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 check the box, as we know that's not effective. We know that's what got us in some of these problems in the first place. Everyone on this call has to think, what can I do differently? How can I inspire learning? It's built on adult learning. We're going to hear a lot about adult learning theories in a minute. It's built on the adult learning theory of metacognition, the idea that the top performing athlete, the top performing individual in your team has a hunger to improve, and improvement comes from identifying weaknesses, focusing on how can I get better by really inspired learning. If you feed that back to me, now you've got my attention. It changes the whole learning model. And then on the right-hand side is where we talk about how do we empower high reliability for the teams. It's the common vision. It's promoting interprofessional teamwork and improvements. We know we're not going to change any of these adverse outcomes if we don't have all members of the care team working. That's really challenging for most organizations. How do we get physician engagement? This is the type of work that these best practices, these organizations we're going to share are doing effectively. And it can be inspiring to those on the call listening today. So the first thing that we need to do in cases to identify variation, I'm giving you an example of one best practice, and then Laura's going to do a deeper dive, which is taking a scatter plot. Scatter plot, in this case, we're looking at judgment versus your knowledge, because that's really the confluence of two in that upper right-hand quadrant, and that quartile is really representing, like, these individuals really are demonstrating some proficiency. They're on their way to mastery. The ones on the lower left need some additional support, which is okay, because we expect that. That's part of creating a highly reliable team, to say, what do I need to do to improve? And so it's non-punitive in any way. It just says, if I'm going to titrate my learning approach, I'm going to use data to be able to inform that decision. So that's what you're looking here. The middle of this is whatever comparative benchmark in a scatter plot you want to use. It may be a national database, or maybe individually, or maybe some of your superstars in your organization create that benchmark. And that's one thing. This is one tenet that we see where organizations are doing effectively in creating highly reliable teams. Do you want to give an example, Laura? Here's.
Yeah, well, I just want, so the thing about this is you're getting, we have protocols, right? We have protocols, care plans, but it's really about, are your clinicians utilizing and able to demonstrate their competency and proficiency in that important content, the kind of content like a stroke protocol, a sepsis bundle. Do they understand and can they apply in clinical scenarios these important knowledge and judgment aspects that lead to good outcomes? And the first thing you want to do, instead of putting in somebody just through traditional education and classroom style and lecturing, and people check out mentally. We know this. We know the adult learning science around this, but if you're able to see, number one, how much variation do we actually have? Because we know variation in delivering care does not bode well on quality and patient safety. So if you're able to measure that and you actually have an empirical data point, you're looking at your team and saying, we have variation here in knowledge and judgment, critical thinking, communication. We have an opportunity to improve this. Without that kind of information, we're really just making our best guess and putting forward and checking the box to say we did an education initiative, we taught people about a protocol, and now we are just going to hope and pray that they're applying it appropriately in the right clinical scenario. So John, if you go to the next slide, we want to take an example, a deeper dive example into this one is obstetric hemorrhage and postpartum hemorrhage. We know this is one of the critical factors that has led to maternal mortality. And we know that this is a group of nurses who have been de-identified. Each dot represents a nurse score. This is an organization where these nurses have been in a classroom style, taught their protocol year over year over year, but yet there have rates of harm and death related to obstetric and postpartum hemorrhage. And we're saying, like, we need to do something different. So this, after they take an assessment, that's testing their knowledge, judgment, critical thinking on all the things they need to know around risk factors, transfusions, what are the interventions? What's the role of the nurse? If a physician was doing this, what are the medical and surgical interventions? And you can see the variation across the team. And you don't really have to continue to focus on those individuals that are above that 50th percentile line, the blue crosshairs, but you're really focused on those that are scoring poorly, and not in a punitive way, but a way that says, how can we help these clinicians get better? Because that potentially represents risk and patient safety issues for your patient population. So this is one example of clients that we work with that are measuring variation, and they're getting this data, and then they're taking it to the next level, which is not only can you see how much variation you have in the scatter plot, but you can see by clinical practice area. So we could tell you what your overall knowledge is and what your overall judgment is. And think about that for a second, because we know judgment comes with experience and time, and not everybody is comfortable with that. Think about your new nurses, think about your changing workforce, and it's a very dynamic time. So if you are not aware of or have your finger on the pulse of what your team looks like in any one of your care areas across your organization, we really don't know what we don't know. So that's a risk for us in the hospital. John, anything else you want to add there?
It's fantastic, Laura. Good.
Excellent. So I think this next piece we want to talk about is this, kind of the principles of adult learning. We know that as adult learners, and I hear this all the time. I mean, we're doing hundreds of consulting engagements every year across some of the largest health systems, in the country. And even though we know And we have some really brilliant people, educators and thought leaders. We still do traditional classroom style education. We're not applying what we know around how an adult learns. They're internally motivated, self-directed, bring life experiences and knowledge, goal-oriented, practical. They want to be respected for their time. Sitting a physician, and they're just not going to participate in education where you need them to, and they need to have buy-in. They're not going to sit in a classroom style education and be lectured to. That's not respecting their time or their expertise. So we have to use, different modalities of learning. Same with and teaching. Same with the, different learning styles: visual, auditory, tactile, experiential. I love that hashtag truth. Preach. Right? I know you all, you're deeply embedded in this. And concept, skills, and judgment. It's, if you think about it, what we've been doing, and we've been testing the short-term memory of what they can memorize from a paragraph or a class that they took. They take a post-test and you're like, we want you to have an 80%. We've literally just tested your short-term memory, but we know that that does not stay with the clinician long-term in an emergency situation, because we've not created that circuitry in the brain. And so that's what Mike Connell, that's a psychometrician at MIT that we've worked with for years in developing our model, our best practices, our education software, and really understanding at the deepest level how an adult learns, and actually building something that is quite unique from traditional, learning, and incorporates all of this.
So we thought it'd be helpful to give you an example of a model, and again, inspire you to think as you go back in some of the training modalities you're using. This is a great example where you can appeal to all kinds of learning styles. Talk about the state of the art in adult learning. What you're seeing here is a procedure that will relieve the shoulder and the shoulder dystocia. So think about that team. They have minutes to save this child. Once that's identified, we have 8 minutes before anoxic brain injury, permanent death, maternal death, every adverse event untoward outcome you can imagine. So you don't have time to think about it. This has to be muscle memory. And so using these type of training approaches do a couple things. One is it appeals to all types of learners, auditory, visual, and text-based, all combined in one approach. You have a passive learning environment where you can sit back and watch this, or you can manipulate this. You can use this in a synchronized training. You can use it asynchronously as an individual, but you can also use it in synchronized training to create that shared mental model that we keep talking about. So that, imagine that when your team imagines a suprapubic pressure, they imagine shoulder dystocia, they have that same mental image. That's how you create high reliability. So these are tools that you have available to yourself to think of how can I apply some of these, how can I apply some of these best practices, these adult learning principles into the training that I'm currently performing in our hospital. And the reason we're belaboring that point, as it were, is because we have a couple examples here of impact. So we're going to take a little time and walk through. We have just 2 case studies. We have 15 minutes left, so we're going to come up for air for questions. But we wanted this part of it to be aspirational for everyone on the call, because these are exemplars, and we really want to spend a little bit of time on this. So everything we talked about in this whole presentation is encapsulated in this one case study. This is an organization who has high reliability. This is an organization that has a culture. This is an organization that has a focus on failure, so they can constantly iterate and improve. And they published in the Journal of Patient Safety and Risk Management on October 19th. Dr. Nancy Kostler and Peter Pronovost, some on the call, most of the call probably recognize Peter Pronovost's name. He's a leader in the quality and safety movement in the United States. In this case, they looked at, and again, we're focusing on LB, but again, it does this type of work. High reliability goes across the entire continuum. This is just a perfect example of putting these principles in place and seeing a dramatic improvement in an outcome. So in this case, over a 4-year period, by following these principles that we've been talking about in this whole presentation, they saw a 91% reduction in OB serious events, which in their case translated 72% reduction in OB litigation, which is $34 million translated out, $34 million in that. But more importantly, that's reduced patient harm. That is mom and baby going home from the hospital, right, to where they should be, and that's over in the far right-hand corner. You can see some examples of that. In this case, over that same period of time, they saw 88% reduction in shoulder dystocia claims. So there's a direct correlation between all of this work and improved care. And one of the questions we received is, hey, is there any evidence? Where's the data that supports creating high reliability? That's right here. And we hope many of you on this call will avail this. And then you can call the organization, you can get this paper anywhere. We're happy to share this with your organization, the full publication on it. But the highlights are shoulder dystocia, 88% reduction, HIE litigation, hypoxic ischemic encephalopathy, 96% reduction. They had 0 cord gases below 7.0. So those who are in OB will recognize that that is unprecedented. It's hard to even imagine that kind of a high reliability, as it were.
Yeah, John, I wanted to add real quick too that, you know, the OB has been an exemplar model, and I, even in my days at Ascension Health, even the work that we were doing in the, you know, starting the zero, you know, harm campaign, at the same time, IHI was launching the 100,000 Lives campaign. And again, that's had, you know, several iterations and continues to evolve and grow, patient experience, et cetera, you know, clinician burnout, efficiency, effectiveness, you know, of cost and of healthcare, et cetera. But you can apply the improvement model concepts, which were utilized here in this project, around, you know, creating a standard operating procedure. No stone, you know, was left unturned, with constant iteration of plan, do, study, act. That model was applied here, but year over year education interventions, measurement, going back to say, okay, how much progress are we making? Where else do we need to dial in deeper? Physicians and nurses were held to the same team standards and participation in education. No one is acquiescing to anybody, right? It's all about mothers and babies, and that was kind of their call to action around this. So just huge, huge improvement, and a brilliant milestone paper, because they really published their pre and post harm rates and claim rates for electronic fetal monitoring, hemorrhage, hypertensive disorders in pregnancy, and injuries associated with shoulder dystocia. Somewhat unprecedented. They really opened kind of the lid off and let everybody take a deep look inside. But that is how when you have that level of transparency, that's how you really start to change practice. You're not on a witch hunt. You're literally trying to improve care, and that saved lives. So really an incredible opportunity to work with them.
That's great. And one last one we wanted to share was now, of course, claims is a proxy for better care, but obviously claims can be crippling to organizations. When you're able to manage those effectively, those dollars can go back into the system. Is exactly what happened in this case. But in this story, we wanted to share with you that there's, in this case, again, a direct correlation between the initiatives that we're talking about, everything that we're talking about encapsulated in this initiative as well. This organization went on a quest for zero preventable adverse events in emergency medicine and obstetrics. And what you can see is the beginning, the precipitous drop right out of the gate early on, and as the lines intersect and drop from claims frequency and participation. The more participation, the more enculturation of these initiatives that we're talking about, there's a direct correlation between claims frequency dropping. So back to that great question, by the way, someone who sent it ahead of time, where's the data with supports high reliability? You know, these are just two of multiple stories that we can tell that it's worth the effort. It is challenging work. It's difficult to be a change agent inside of your organization, but the stakes are too high in healthcare for us not to do everything that we can to improve outcomes and reduce risk. So we're going to stop right there and turn back to Laura for a last comment on this. And also, you're also able to open up the chat and see if we have any other questions, or we got a few minutes left.
Yeah, I don't really have any anything else to add to that. I think we just have been able to consistently see across the country, which is the work that we do, from being frontline and being taught this and applying it in a clinical role, but now from a consultative component, seeing what organizations are doing nationally. And even in the face of COVID and this pandemic, organizations that have high reliability and take it very seriously and consistently have done better and are maintaining improvement. But they're also, not drinking their own Kool-Aid to say you can never rest on your laurels. They are seeing increases in hospital-acquired conditions and infections. And so going back to the basics might be a great strategy and a tool for, I would think is the takeaway. And that's some of the things that we're seeing. So Nathal, I'll turn it back to you and you can lead us through some Q&A.
Laura, thank you. John, thank you so much for a great presentation and discussion. A lot of good energy and comments and questions coming in on the chat. So let's try and get through as many as we can. I'll start with a good one that we got just in a couple moments ago around just implementation. There's somebody in our audience who's part of an HRO implementation team, and they're asking a good question on just engagement for those individuals that might have low or no engagement or struggling to increase engagement. Any thoughts on how to combat some of that?
Well, it's a great question, but we are seeing it everywhere. And I think, the pandemic kind of appropriately, teams had to respond to the pandemic, the changing dynamic of the workforce, the prioritization of what we were experiencing. But what we're seeing and what we're hearing from C-suite leaders across the country in big health systems, community hospital systems, standalone hospitals is getting back to basics and reconfirming the commitment to high reliability and going back to those basics. That's my advice. And having a team who is responsible to oversee that is fantastic, but you also have to instill it in your leadership and the C-suite, the mid-level leaders and line leaders to make sure that it's being carried through the water up and down. And you have to, and people know what I'm talking about on this call. It's somewhat like preaching to the choir here, but that's what we're seeing nationally. John, anything you'd add?
Yeah, I would also say that when you first said that, my first instinct is, well, that's probably physicians, let's just say it, physician resistance, and especially with voluntary attendings or disconnect. And the story we shared with you with that organization that had all of that success really came down to incentives. They put incentives in place to make sure that they got engagement, and the dollars just follow from that perspective. Now, I know some structures don't allow that, but in the case of medical malpractice, there are tremendous opportunities to have these initiatives tied to reduced harm. Initially, the Quest, Laura, that was a perfect example. And those incentives drove participation. So that person who's asking that question, yes, it's a challenge, but you're also absolutely right on. It comes from leadership down. It has to be, in the entire building has to be engaged on that. Everyone has to stack hands and move forward. So. Well,
and the thing is, you have to this question from Fabio around, comment in chat. When you're tied up with operational issues, do organizations have positions for people to do this work full time? And the answer around that is yes. Yeah. But if you have an organizational structure that is more inclusive and more transparent, and you're training more people to be part of the solution, we're seeing, titles of patient safety nurses. we're seeing risk managers and quality nurses becoming risk patient safety. So it's a joint role. So we're seeing lots of good organizational structure, but I think that committee structure that is tied to the top, that is, and each concentric circle gets bigger till you're literally covering the entire organization. Yeah, safety coaches is another great way to be thinking about it.
Right, and I want to also say that we talked a lot about adult learning, and that was really designed to inspire everyone to think we've got to think differently, right? The resistance comes down to like, how many times you made me traffic through that initiative du jour, you took away from my home life, you took away from my practice, it didn't get any value. So that is antithetical to everything we're talking about. We cannot do that anymore. That's not working, it's not effective, it's not inspiring, and that's where you get resistance. If you apply some of those principles we talk about in adult learning, respect their time, respect their competency, reward their competency, right? Hey, you did this assessment up front, you're doing this, and this. All we need you to do is focus on these things. That's inspiring. That's something that change. Also, temporal education makes a big difference. It's not, we're going to put you in a room for 8 hours in June or September. We need to do this on a temporal basis, smaller bite-sized contents, micro learning, lightning learning, little pieces like that has been proven over and over and over to be more inspiring and sustain the education. We talked about a moment ago, cramming for exams and testing on that. We've all done it. It's not effective. You work a week for that and then you never remember anything else. So think in those terms. How can I flip that to make something inspiring? The last thing I'll say is that this whole world that we're talking about of improvement really comes down to blended solutions. So think of those blend. There's an important role in instructor-led and simulation, and didactic can play a tremendous role. Anything you can learn asynchronously, you should be promoting that. Hey, come to this sim lab with that knowledge, because then I can get super efficient. I can focus on something we can all move forward together instead of using synchronous training to bring everybody up to speed. You've got to come to that meeting up to speed, and then let's take you to that next level, right? So I think about one analogy, sorry, it comes to mind. We focused a lot on the Navy SEAL team that took down bin Laden back, and they talked a lot about just what everything we talked about, of course, in a highly reliable team. But in their approach, the pre-mission was to prepare and to come to those simulated events with that baseline knowledge, right? Everything we're talking, they were measured, everybody had a shared mental model, common vision, what we're doing, and then they simulated it over and over and over. And when it was time to act, they went right into execution. So that's the same thing we need to create with teams, especially in OB, because we don't have any time. We have just minutes. We need to be able to kind of have that muscle memory that we've learned. So that's one encouraging. Resistance comes down to, you can learn a lot of this on your own, and then I'm only going to put you in the sim for this period of time. Let's get super efficient about training. That's inspiring. Simulation, yes, and seeing that simulation, absolutely.
Yeah, thanks for that, John. We have 1 minute. I want to get one more question, which I think is a good one, as you think about this toolkit to get to high reliability organizations. How do we leverage technology? EHRs are having more and more kind of system-based checks and balances, safeguards. Where do you see that going? I would love to get your thoughts on that.
Absolutely. I mean, we think about that a lot at Relias. We think about that's the next generation tool, because or next generation of learning, because that's really in situ learning. You're inside of a tool that you're not going to a disparate location to have a training. The training becomes more ubiquitous, right? It's more of your workflow. So I absolutely see that moving time. I'm actually surprised it's not as advanced as it should. We've been following that forever. Same thing with wearables. We think a lot about wearables at Relias and what role at data. So think anywhere where there's assessment is remediation learning. So once we identify something, so assessment can come in the form of the way you're trafficking through your EHR, the way you're diagnosing, the way you're interpreting an MRI. That's assessment. You're saying, okay, this individual missed this piece, let's plug in remediation. So that is absolutely where the future of learning is going.
Definitely.
Well, John, Laura, we are at time. So thank you so much for this great discussion and presentation today. For those of you who've asked a question that we can't get to, we will follow up with you offline. A couple closing remarks before we end here. We will make the slides and presentation available to you, so that we'll get that over to you. And then when you close out here, you'll see an evaluation prompt. If you can take the time to fill that out thoughtfully, we take your feedback very seriously here, and we want to do a better job and continue to improve. So thank you for your thoughts, and thank you for your time, everyone. Have a good rest of your Thursday. Bye-bye.
I know.